I'll turn to my colleague and ask you specifically, maybe you can describe a little bit about what Tebentafusp is, why it might work, how it works, and then kind of go into some of the data, and then maybe we can kind of go back and forth in terms of our experience using this drug.
Thank you. I mean, it's unbelievable to say that we have an immunotherapy now for metastatic uveal melanoma that's FDA approved. As you've said, historically, this has been an immune desert where nothing really works. So the idea of checkpoint inhibition, while it had low response rates, was the beginnings to understand that we need to bring in T cells into the tumor environment. So Tebentafusp, which is now called Kimmtrak, it's a bispecific GP100 peptide HLA-directed CD3 T cell engager. That's a lot. And it's indicated for HLA-A201 positive adult patients with unresectable or metastatic uveal melanoma. It goes by different names, but we call it an ImmTAC, or an immune mobilizing monoclonal T cell receptor against cancer. It's a T cell receptor. I like to think about it as a double-sided antibody bringing two things together, or like a matchmaker. On one side, it is a binder of a T cell with an anti-CD3 cluster of differentiation end that would only be attracted to the T cell. And on the other end, it binds the antigen GP100, which is found on the surface of the tumor. So these two, this dual antibody forces the T cell to get into the area and engage with the cancer. And just like a matchmaker that makes a good match, this makes a bad match for the cancer. This allows the T cell to then become activated and then to attack the cancer. So, because of the immune system itself not being able to acknowledge uveal melanoma, this drags the immune system over to the cancer and forces them to engage. That's the simplest way to say this. As a target, GP100 is uniformly expressed on uveal melanoma. But the other place we see it is most commonly is in the skin, and that leads to some of the side effects of the rash. I did say that this is in HLA-A201 positive patients. That's about 50% of Caucasian patients and 25% of non-Caucasian. So you need this recognition of GP100 in the context of HLA-A201. So it's important for our audience to know what HLA status is, human leukocyte antigen. This is what I would say is the identification of your immune system, what we use to find the perfect match for transplant, etc. So this drug was designed only to identify the fragment in the context of HLA-A201. So only patients that express that HLA type are candidates for this therapy. So how do you test that? The most common way is a simple blood test. And in our initial clinical trials, we consented patients to have a little bit of blood drawn and sent, and the Red Cross does that. Multiple labs do this. There are other ways to test it by looking at tumor tissue, but this is the easiest way, and this is the way that it's been FDA approved. So the way that we administer Tebentafusp is intravenously, and we administer this intravenously weekly in a dose escalating fashion, which is an initial dose based on 20 micrograms, then 30 micrograms, and then the full dose 68 micrograms, in order to allow the patients to become to avoid the major side effects that we've seen on this. And that's cytokine release. We'll talk a little bit about that. The patients that are treated, the first 3 weeks need to be evaluated for 16 hours to see that they don't have the cytokine release syndrome. So that's the logistical burden here that we're learning to do more. This is T-cell therapy, which is new. This is a bispecific, which is new. This has shown benefit for the patients, but it does have you administered in different ways and monitor. Now, I will say that if you have issues as a physician or want to know more about it, there is a lot of support through KIMTRAC Connect. I don't need to say more about it, but they help you, case managers help you for one-on-one to tell you how to coordinate care, how to access this, how to help with financial assistance and site coordination. So what I find amazing is this is a T-cell therapy that has been tested in clinical trials and approved and has come into our clinics in a very rapid fashion through this mechanism.
You know, Dr. Mee, can I ask you, how do you guys handle the 16-hour observation? Because you might imagine a few different scenarios. One scenario is probably not treating somebody at 2 a.m. and then, you know, watching them through till 8 p.m. So how do you handle that at the Angeles Clinic?
Well, for us, what we really do is we arrange for them to be evaluated overnight in a local hospital in a less than 24-hour situation. And for the clinical trials of these types of therapies, and there's more coming out now, we infuse them in the clinic, we watch them for 8 hours, and then as the clinic is beginning to close, they're transported to the hospital. There are orders and they're monitored, and we see them in the morning before discharging them home. And that's a lot initially to do if you're not familiar with it. But as we say, see one, do one, teach one, it becomes very easy. And we have multiple patients during the week going through this cycle.